Hi, welcome to our channel of IGNOU Audiobooks, Indira Gandhi National Open University, School of Continuing Education, SOCE Master of Science, Food Nutrition, MSCDFSM, Revised. Second year. MFN-004 Advanced Nutrition. Unit-13 Pregnant and Lactating Mothers. 13.1 Introduction. In the previous unit, we learnt about the basic principles of meal planning and the various considerations and guidelines that must be kept in mind while planning the diets for adults. In continuation with our discussion on adults, let us move on to study about the nutrient requirements during the periods of pregnancy and lactation. Pregnancy and lactation are unique periods in the life cycle. They occupy a critical place in the life cycle and have health and social importance for individuals, families and society. This intergenerational significance has led all societies to recognize these as special periods and to make provisions for their care. This unit discusses the various issues pertaining to these two important physiological stages, such as meeting the nutritional requirements during these periods. It focuses on nutrition in preparation for, and support of, pregnancy and lactation. As you read on, it will become evident to you that there are heavy demands on the mother during pregnancy and lactation. What modifications should be made to meet the increased needs? Which foods must be included in the diet of pregnant/lactating women? Let us proceed with our discussion and find out all these aspects. Objectives. After studying this unit, you should be able to describe the various physiological changes during pregnancy. Describe fetal growth and development and understand the importance of nutrition. Identify determinants of poor pregnancy outcome. Explain what is infant LBW and their consequences. Discuss the various aspects about lactation and importance of human milk. Elaborate the nutritional requirements during pregnancy and lactation. State dietary considerations to be followed to ensure successful pregnancy and lactation, and counsel mothers as per their individual requirements. 13.2 Pregnancy and lactation critical stages in the life cycle. You must be aware that the situation of women is far from optimal and it is necessary to give attention to their nutrition and health. The National Family Health Survey, NFHS4, 2015-16 indicates that the mean BMI for women is 21.9. Asia has the highest prevalence of anemia in the world, with about half had anemia during pregnancy. As per the data of NFHS4, 2015-16, 53% of women are anemic, where 50% had anemia during pregnancy. Undernutrition in children is strongly associated with undernutrition in mothers. It often starts in utero and may extend throughout the life cycle. It occurs during pregnancy, childhood and adolescence and has cumulative effects. Undernutrition, especially in the mother, is associated with poor pregnancy outcome, including a higher incidence of low birth weight, maternal mortality, fetal and infant death and disability. Malnourished women or adolescent girls give birth to stunted and thin babies. Thus, undernutrition is handed down from one generation to another. Such children may not show catch-up growth in the later years and are more likely not to perform well in school. As adults, they may be less productive and are more likely to suffer from chronic degenerative diseases. Chronic undernutrition accounts for a large proportion of child deaths, poor pregnancy outcomes, poor quality of life and lost productivity among earning adults and spanning generations. At no other period is the well-being and future of an individual completely dependent on the health and nutritional status of another as is during pregnancy and early periods of lactation. The mother's nutritional status is a crucial factor affecting pregnancy outcome. Her diet must be carefully planned to supply the nutrients needed to maintain her health, support the physiological changes in her body and provide for the rapid growth and development of her unborn baby while protecting her from deficiency or excess of nutrients. The goal is not just survival. We must try and ensure that every woman who is pregnant has the opportunity for a safe and successful pregnancy and the ability to deliver and care for an infant whose physical and mental potential are not impaired. Once a child is born, she must be adequately nourished to continue to depend on their mothers for nourishment. Lactation has high nutrient costs, hence the mother's diet must be nutritionally adequate. Let us then understand these two physiological conditions in greater details. We begin with pregnancy. 13.3 Physiological changes during pregnancy. A whole new life begins at conception. Organ systems develop rapidly and nutrition plays many supportive roles. Pregnancy from conception to birth usually lasts 40 weeks, 10 lunar months/menstrual cycles, in humans. During this period, the unborn child grows from a single cell to an infant that is ready for life outside the womb. Many physical changes also take place in the mother to support her developing offspring, regulate her own maternal metabolism and prepare her for labor, birth and lactation. Changes in the mother are anatomical, physiological and complex, affecting almost every function of the body. They are an integral part of the maternal, fetal system, which creates the most favorable environment possible for the developing child. Many of these changes are apparent in the very early weeks. Let us briefly look at the important physiological effects, which will help you to understand the basis of nutritional requirements. 13.3 Expansion in plasma volume and red cell mass. In this subsection we shall review the expansion in blood volume and in the red cell mass accompanying pregnancy. Plasma. In a non-pregnant woman, average plasma volume is 2600 milliliters. Plasma volume begins to increase by end of the first trimester and reaches a peak by 34 weeks, when it is about 50% greater than it was at conception. The physiologic dilution accompanying the expansion in blood volume is known as hemodilution. Hemodilution is responsible for the decline we see in several blood parameters during pregnancy, especially in the second and third trimesters. Individual variations are seen in plasma volume. Multigravidas and in mothers with multiple births usually have a greater increase. Increase in plasma volume is correlated with obstetric performance. Women with an increase smaller than the average have higher risk of stillbirths, abortions or low birth weight babies. This has been seen in women with hypertension, renal disease, low weight gain during pregnancy, undernutrition, smoking, preeclampsia, diuretic treatment and smoking. Red cells. Production of red cells is stimulated and their numbers gradually rise. However, as compared to the expansion in plasma volume, their increase is not as large. There is an increase in red cell mass by 20%. As the plasma volume increases much more than the red cell mass, there is usually a drop in the hemoglobin levels around 34 week of gestation. Proteins. Total serum protein gradually decreases, along with a sharp decline in albumin. There is reduction in serum albumin along with the expanded plasma volume. Serum levels of vitamin C, folic acid, vitamin B6 and vitamin B12 follow the decline of serum albumin levels. Other nutrients. Fat-soluble vitamin concentrations, especially carotene and vitamin E, are increased by nearly 50%. Vitamin A levels, however, remain unchanged. Progressive increase is seen in serum triglycerides, cholesterol and free fatty acids. These are brought about by increased concentrations of estrogens, progesterone and placental hormones. Interpretation of blood/serum nutrient values in pregnancy is therefore complex compared to the non-pregnant state, as they depend on a number of factors including the stage of gestation. It is necessary to conduct biochemical tests at suitable intervals such as in the first, second and third trimesters, to follow these changes and determine if there is a deviation that calls for an intervention. The most common measurement of nutritional importance done routinely in India is hemoglobin in the second and third trimesters. Measurement of blood pressure and fundal height are other two measurements done routinely to determine high-risk pregnancies and development of the fetus. 13.3 Hormonal profile in pregnancy. Hormonal changes characteristic of pregnancy include the following. Human chorionic gonadotropin, HCG, begins to increase immediately on implantation of the ovum and reaches a peak at around 8 weeks of gestation. It then declines to a stable value until birth. In the first 8 to 10 weeks, HCG maintains the corpus luteum, which is the main source of estrogens and progesterone in the early weeks of pregnancy. These hormones play an essential role in the development of the placenta. Human placental lactogen, with a structure similar to the growth hormone, increases throughout pregnancy. Its rate of production parallels the rate of placental growth and is a good indicator of placental function. At the peak rate of secretion, the amount produced is 1 to 2 grams per day, much higher than any other hormone. Placental lactogen stimulates lipolysis and is important in maintaining a flow of substrates to the fetus. Placental lactogen along with prolactin also promotes the development of mammary glands. After delivery, placental lactogen disappears from the maternal circulation. Estrogens and progesterone are secreted by the placenta from 8 to 10 weeks of gestation. Progesterone increases throughout pregnancy. It stimulates maternal respiration, ensuring an adequate supply of oxygen to the fetus. In addition, it relaxes smooth muscle in the uterus to accommodate the growing fetus and allow for childbirth. Progesterone, while stimulating lobular development in the breast, inhibits milk secretion during pregnancy. Placental secretion of estrogens increase with progression of pregnancy. Estrogens perform many functions. They stimulate uterine growth, increase blood flow to the uterus and promote breast development. Estrogens also induce prolactin secretion by the maternal pituitary. Prolactin secretion helps in mammary gland development. After delivery, estrogen-induced mammotrophes, prolactin-secreting cells, in the pituitary secrete large amounts of prolactin to initiate and maintain milk production. Another hormone that is increased in maternal plasma during pregnancy is cortisol. Cortisol enhances production of glucose from amino acids, gluconeogenesis, and also antagonizes the action of insulin. This way it increases the availability of glucose to the fetus, which relies solely on glucose for its energy needs. In the marginally glucose-intolerant women, these changes as a result of pregnancy may predispose them to frank impaired glucose intolerance. 13.3.3 Organ functions. Dramatic changes occur in renal functions to eliminate the nitrogenous and other waste products of maternal and fetal metabolism. Effective renal plasma flow, volume of plasma filtered by the renal tubules, increases by 75%. This is one of the earliest physiological adjustments in pregnancy. The glomerular filtration rate increases by 50% in early pregnancy. These changes in renal functions, while helping to clear waste products on one hand, are also associated with increased excretion of glucose and amino acids but unrelated to the plasma levels of these constituents. In addition, the heart and the lungs respond suitably to the increased blood flow to the placenta and to the increased demand for oxygen to the fetus. The intestinal absorption of all nutrients is enhanced to take care of the increased requirements. The amount absorbed depends on the amount ingested, maternal stores and progressively increasing requirements of the fetus. 13.3.4 Placental transfer of nutrients. The placenta is a transitory structure developing during pregnancy and lies implanted on the uterine wall. It is connected with the fetus through the umbilical cord. The fetus derives all its nutrition from the mother across the placental barrier. If the consumption, absorption and utilization of the nutrients by the mother and the transport of nutrients across the placental barrier are inadequate, then fetal malnutrition develops. Dietary inadequacies are a major cause of fetal undernutrition in developing countries. Maternal diseases such as diabetes and hypertension compromise the delivery of nutrients across the placenta to the fetus. The transfer of nutrients also depends on their concentrations in maternal plasma and blood flow to the placenta. The mechanisms for transfer of nutrients across the placental barrier are either simple or facilitated diffusion or active transport, as in the case of transfer across the intestinal brush border. Fat-soluble vitamins and electrolytes are transferred by simple diffusion, glucose is transferred by facilitated diffusion, while amino acids, water-soluble vitamins and minerals like calcium and iron are transferred by active transport. The role of placenta in promoting fetal nutrition is shown in the Table 13.1. Table 13.1, Role of the placenta in fetal nutrition. Nourishes the fetus, facilitates transfer of oxygen and nutrients from mother to fetus. Removes wastes, picks up fetal waste products such as CO, urea, bilirubin. Fetal lung, performs the respiratory, absorptive and excretory functions that the fetus lungs, digestive system and kidneys will provide after birth. Protective barrier protects the fetus from harmful agents, which are of high molecular weight including proteins except maternal immunoglobulin G conferring immunity to the fetus. Transports nutrients and in some cases can store them. Endocrine gland produces several hormones that maintain pregnancy and prepare the mother's breasts for lactation. 13.3.5 Maternal weight gain. The often quoted figures for weight gain during pregnancy are from the study of Hitton and Leach reported from UK in 1971. In this study, average weight gain by primigravida eating without any restriction was 12.5 kilograms. This weight gain represents two major components. 1. The products of conception, the fetus, amniotic fluid and the placenta. 2. Maternal tissues gained, expansion of blood and extracellular fluid, enlargement of uterus and mammary glands and maternal stores, adipose tissue. In India, several studies have examined the weight gain during pregnancy by women from upper and lower socioeconomic groups. In the Indian reference women with pre-pregnancy weight of 55 kilograms, the body weight gain may be 10 kilograms. Among lower economic groups, the data indicates that the mean height of Indian women is about 151 centimeters and the mean body weight is 47 kilograms. The average pregnancy weight gain in this population is only 7 to 8 kilograms during pregnancy. Lower weight gain is associated with increased risk of intrauterine growth retardation and perinatal mortality. It is useful to define certain terms here. When a baby is born full term, 39 to 40 weeks of gestation but has a weight less than 2.5 kilograms, the baby is referred as a low birth weight, LBW, baby or as a small for-date baby. These babies have suffered intrauterine growth retardation, i.e., retardation in growth in utero. If a baby is born prior to full term and weighs less than 2.5 kilograms, it is not to be classified as low birth weight or small for date. Such babies are prematurely born. However, in many developing countries, obtaining correct information on gestational duration is difficult and therefore quite often the babies born before full term and weighing less than 2.5 kilograms are classified as LBW. The developmental trajectory of a preterm baby is quite different from that of a low birth weight baby and therefore it is important to distinguish between these two. The rate of weight gain is as important as the total weight gain. The rate of weight gain as pregnancy progresses for three categories of women: underweight, normal and overweight prior to pregnancy is shown in the graph in figure 13.1. Look the screen. Figure 13.1, recommended pattern of weight gain. Source, Smolin and Grosvenor, 1997. As you may have noticed in figure 13.1, little gain occurs during the first trimester, approximately 1 kilogram. In the second and third trimesters, when the fetus grows from less than 500 grams to about 3 kilograms, the weight gain should be approximately 3 kilograms, 1 kilogram/month, in the second trimester and 6 kilograms i.e., 2 kilograms/month in the last trimester. This translates to approximately half a kilogram per week. Although the total recommended weight gain is different for underweight and overweight women, it should be at a slow and steady rate. See figure 13.1. The recommended weight gain on the basis of pre-pregnancy weight for height in the case of undernourished women is almost unattainable in India. For example, for women with pre-pregnancy BMI of less than 19.8, the total recommended weight gain is 12.5 to 18 kilograms, an impossible target for the Indian women, 1/3 or more of whom have a pre-pregnancy BMI of less than 18. This brings out explicitly the need to address undernutrition in the early years and during adolescence so that realistic targets can be set for weight gain in pregnancy. For women with normal BMI of 19.8 to 26, the recommended weight gain is 11.5 to 16, while for the obese with BMI of greater than 26, the recommended gain is 7 to 11.5. In the Indian setting, a total weight gain of 10 to 12 kilograms appears reasonable. So far we have read about the physiological changes which develop during pregnancy. These physiological changes contribute towards the increased nutrient demands on the nutritional status of the expectant mother. Through our subsequent discussions, you will be able to learn about the nutrient requirements during pregnancy. 13.4 Nutritional needs during pregnancy. It must be evident by now that several physiological changes occur in the body of an expectant mother and that malnutrition can adversely affect the health of the mother, as well as that of the infant. In this section, we shall study about the nutrient requirements during pregnancy. For most women, nutrient needs during pregnancy are higher than at any other time of life cycle. Let us get to know about the energy and other nutrient requirements during pregnancy. We shall begin with the calorie requirements and proceed to the need for various macro and micronutrients. Energy. Two factors determine energy requirements: increase in mother's basal metabolism to support the work required for fetal growth and accessory tissues, and changes in the mother's usual physical activity. The estimated total, cumulative, additional cost of energy is 55,000 kcal. It works out to be an additional 350 kcal per day in the last 2 trimesters for an Indian woman of 55 kg body weight and pregnancy weight gain between 10 to 12 kg. Refer to Table 13.2 for recommended nutrient intakes for pregnancy. Note, during the first trimester the additional energy required is small, hence the RDA is not increased. Nutrient. Table 13.2, Recommended dietary intakes during pregnancy. Look at the screen. FAO/WHO/UNU 2004 recommendation for the extra energy cost of pregnancy is 85 kcal/day, 285 kcal/day and 475 kcal/day during the first, second and third trimesters, respectively. There are many societies with a high proportion of non-obese women who do not seek prenatal advice before the second or third month of pregnancy. Under these circumstances, FAO/WHO 2004 recommends that in such societies pregnant women increase their food intake by 360 kcal/day in the second trimester and by 475 kcal/day in the third. The composition of the diet during pregnancy should be the same as for a non-pregnant woman, hence the contribution to calories from carbohydrate, protein and fat does not change. The suggested minimum requirement for carbohydrate for pregnant women is 135 grams/day, which is derived from the requirement of the non-pregnant, non-lactating women, 100 grams/d. Flues the additional requirement for the fetus during the last trimester, 35 grams/day. Pregnant adolescent girls, underweight women and women who are exceptionally active, heavy physical activity, may require more energy. The details of these specific cases and increased needs are discussed later in this unit. However, here it is important to remember that requirements vary with pre-pregnancy weight and body composition, amount and composition of weight gain, stage of pregnancy and activity level. Therefore, it would not be appropriate to make a single recommendation for all pregnant women. Energy status may be estimated by evaluating the rate of weight gain. If the rate of weight gain is appropriate for the stage of pregnancy, you can assume that energy intake is adequate. Fasting is not recommended, for it may be a special risk for women with a tendency towards early delivery. Chemical changes associated with fasting may precipitate labor pains. Some mothers may ask you whether they can diet or undertake fasting. Studies on animals show that when the mother's diet was restricted, fetal body weight was significantly reduced. Data on humans is rather limited. However, among mothers experiencing food shortages, infant birth weights get reduced. This has been documented in the studies from World War II. Optimal fetal growth occurs only when the mother is able to accumulate a critical amount of extra body stores during pregnancy. Next, we shall discuss about one of the most critical nutrients required for tissue synthesis, i.e., protein. Protein, altogether, 925 grams of protein are deposited in a normal fetus and maternal accessory tissues. Therefore, an increase of 9.5 grams/day for second trimester and 22.0 grams/day for third trimester for additional 10 kilograms gestational weight gain, GWG, is recommended. This increase could be either through vegetarian sources such as pulses, soybean, milk and milk products, cheese, or through more of meat/fish and eggs in the diet. This is based on the needs of the non-pregnant woman plus the extra amounts needed for growth. The physically active pregnant women and adolescent girls would however require more as compared to sedentary pregnant women. The protein excess/supplements are not recommended as these were associated with an increased incidence of prematurity and enhanced incidence of neonatal death. The rate at which new tissue is synthesized is not constant throughout gestation. Maternal and fetal growth accelerates in the second month and the rate progressively increases until just before term. Therefore, the need for protein follows this growth rate. It is important to ensure protein quality, as well as quantity. Moreover, since protein utilization depends on calorie intake, it is important to ensure that calorie needs are fully met. When there is inadequate intake of energy, protein will be catabolized to meet energy need. Under such circumstances, it has been shown that extra 100 kcal will have the same effect on nitrogen retention as an additional 0.28 grams of nitrogen itself. Additional protein requirements in pregnancy according to gestational weight gain, GWG, has been highlighted in Table 13.3 below. Table 13.3, Additional protein requirements in pregnancy according to gestational weight gain, GWG. Look at the screen. Protein deficiency. The effects of protein deficiency during pregnancy are difficult to separate from the effects of caloric deficit, since in almost all cases, limited protein intake is accompanied by limited energy intakes. Under such circumstances, decreased birth weight and greater incidence of preeclampsia have been reported. Protein excess. It is not advisable to recommend protein supplements. Reports in the literature indicate that high-protein supplements were associated with increased incidence of prematurity and excessive neonatal deaths. Analysis of supplementation studies in human populations suggests that supplements providing more than 20% of the calories from protein are associated with retarded fetal growth. Apart from proteins and non-nitrogenous sources of energy, several vitamins, minerals and trace elements have been found to play a critical role in the progression and outcome of pregnancy. We will now review some of these in detail. Micronutrients. The need for many vitamins and minerals is increased during pregnancy. Since energy intake increases, the requirements for few micronutrients needed for energy utilization i.e., thiamine, niacin, riboflavin and magnesium also increase. Since protein needs are higher, the requirements for vitamin B and zinc also increase. Micronutrients involved in the growth and development of bone and connective tissue and the synthesis of new cells are needed in greater amounts. Let us review the requirements for these nutrients. Folic acid and vitamin B2. Folic acid and vitamin B12 are important for production of new cells. DNA must replicate and transmit its genetic information to RNA intermediates. As mentioned previously, folic acid has a role in prevention of neural tube defects. However, we need to bear in mind that effects of high intakes of folic acid are not well known, but it can complicate the diagnosis of B12 deficiency. Therefore, care should be taken to keep total folate consumption under 1 mg/day except under the supervision of a physician. For normal, healthy individuals, the amount of folate present in a multivitamin form containing B12 should be sufficient. Vitamins A, C, E and K. All four vitamins have specific functions and a common role for all of them is to preserve the structural and functional properties of cells. Excessive consumption of vitamin A is known to be teratogenic. Hence, it is not advisable to use supplements. Vitamin A requirements should be met through diet. Also, if women of childbearing age intend using products containing high amounts of vitamin A, they should be advised to consult their physicians before doing so. Vitamin C deficiency has not been shown to affect the course or outcome of pregnancy in humans, although low plasma levels have been associated with the premature rupture of the membranes and preeclampsia. Megadoses may adversely influence fetal metabolism. Metabolic dependency on high doses may develop in the infant such that scurvy may arise in the neonatal period. Vitamin E needs are believed to increase during pregnancy but deficiency in humans rarely occurs. Vitamin E in the infant was correlated directly with maternal concentration. Maternal dietary deficiency of vitamin K is almost unheard of, but transport across the placenta is low. Newborns often have low body levels of vitamin K. Although the need for vitamins A, C, E and K increase during pregnancy, symptoms of deficiency of C, E and K are seldom seen. You should advise mothers to include adequate amounts of these foods in the diet. With the exception of iron and folic acid, routine dietary supplementation with other vitamin and mineral preparations is not necessary. You should encourage pregnant women to disregard vitamin and mineral preparations as corrective measures for inadequate dietary habits and consider food as the optimal vehicle for delivery of nutrients. For women who need supplementation e.g., those in high-risk category, a vitamin-mineral supplement is recommended from the beginning of the second trimester. See Table 13.3 for amounts recommended. Table 13.3 Daily vitamin/mineral supplementation for pregnancy for those with inadequate diet. So in high-risk categories, more than one fetus, heavy smokers, alcohol and drug abusers. Iron, 30 mg. Vitamin B6, 2 mg. Folate, 300 micrograms. Zinc, 15 mg. Vitamin C, 50 mg. Copper, 2 mg. Calcium, 2 mg. Vitamin D, 5 micrograms. Mineral requirements. Iron. While B12 and folic acid are needed for the normal erythropoiesis, they must be accompanied by adequate amounts of other nutrients. Iron is needed for synthesis of hemoglobin in both maternal and fetal red blood cells. At term, a normal weight infant has about 246 mg of iron in blood and body stores. An additional 134 mg is stored in the placenta and about 290 mg is used to expand the volume of mother's blood. Maintenance of erythropoiesis is one of the few instances during pregnancy when the fetus acts as a true parasite. It ensures its own production of hemoglobin by drawing iron from the mother. We should be concerned about the mother's iron nutriture, because maternal iron deficiency may adversely affect obstetric performance. A reduction in hemoglobin concentration means that the mother must increase her cardiac output to maintain adequate oxygen supply to the placenta and the fetus. This extra work fatigues the mother and makes her more susceptible to other physiologic stress. A very low hemoglobin level places the mother at risk of cardiac arrest, and should she hemorrhage on delivery, the prognosis would be poor. The most significant known consequence of maternal iron deficiency is reduced fetal iron stores, followed by increased risk of anemia during infancy. Moderate to severe anemia is associated with increased risk of spontaneous abortion, premature delivery, low birth weight, stillbirth and perinatal death. In some cases, PICO has been associated with iron deficiency. Inadequate weight gain during pregnancy has been found to be more prevalent among mothers with iron deficiency anemia and in those with anemias of other etiologies. If sufficient iron is available, the mother's hemoglobin level should be at 11.5 grams/100 milliliters by term. Most women are not able to meet the additional requirement for iron from diet alone, since the quantity ingested is less, especially in lower income settings, and the bioavailability/efficiency of absorption is very low. Thus, it is recommended that pregnant women receive an oral iron supplement. 60 to 100 mg of iron should maintain hemoglobin levels in normal pregnant women, but those who are anemic will require larger doses. Another important nutrient of physiological significance is calcium. How does calcium intake influence the health status of mother and the fetus? Let us read and find out. Calcium. The fetus retains about 25 to 30 grams of calcium over the course of gestation, most of which is deposited in the last trimester when the fetal skeleton is growing rapidly and the teeth are forming. On an average, the fetus draws 250 to 300 mg Ca per day from maternal blood supply. Additional calcium is believed to be stored in the maternal skeleton as a reserve for lactation. So an intake of additional 500 mg Ca is recommended during both pregnancy and lactation. Extensive adjustments in calcium metabolism occur. Efficiency of calcium absorption is better and urinary losses are lower in pregnancy compared to the non-pregnant state. Hormonal factors play a role. Human chorionic somatomammotropion, produced by placenta, enhances the rate of bone turnover throughout pregnancy. Estrogen largely from placenta inhibits bone resorption, thus provoking a compensatory release of parathyroid hormone. PTH maintains the serum calcium level while enhancing intestinal calcium absorption and decreasing its urinary excretion. Along with calcium and phosphorus, adequate vitamin D is required. Other micronutrients of physiological relevance include zinc, iodine and sodium. Zinc, as a mineral, was found to be associated with fetal growth and birth weight. Low plasma zinc was associated with more complications in the antenatal and intrapartum periods, including pregnancy-induced hypertension. Subnormal tissue zinc in pregnancy may play a role in premature rupture of membranes at term. A point of caution is the interaction between zinc and iron. Zinc absorption is inhibited by high iron intakes, thus iron supplements may compromise zinc status. Box 3.1 gives details regarding the daily intake suggested for Indian adults. Iodine. You would be already aware that maternal iodine deficiency leads to cretinism in the offspring. Hence, the maternal diet must consist of enough iodine so as to prevent the consequences of fetal damage. Box 3.1. Suggested daily intake of trace elements for an Indian adult. Chromium, 67 mg. Copper, 135 mg. Manganese 5.5 mg. Zinc, 14.5 mg. Iodine, 220 mg. Sodium. As you know, sodium plays a role in fluid balance. Sodium metabolism is altered during pregnancy under the stimulus of a modified hormonal milieu. Restriction of sodium is not recommended to combat edema. In animals, it has been shown that rigorous sodium restriction stresses the renin-angiotensin-aldosterone system to the point of breakdown. Such animals show reduced weight gain, altered fluid consumption patterns, and they tend to develop water intoxication along with renal and adrenal tissue degeneration. Neonatal hyponatremia has been observed in offspring of women who unduly restricted their sodium intake before delivery. Although moderation in use of salt and sodium-rich foods may be appropriate, aggressive restriction is not warranted. Not less than 2 to 3 grams of sodium should be consumed daily. After studying about nutritional needs during pregnancy, let us focus on balanced diet for pregnant women given below in Table 13.4. Table 13.4, Food Composition and Nutrient Content Value of Balanced Diet for Pregnant Woman. Look at the screen. 1. Protein quality depends on the type of foods. Pulses can be replaced with animal foods, egg, meat, fish and chicken, for non-vegetarians to meet the requirements. Only 80% of the RDA of vitamin B12 can be met by the vegetarian diet. Retinol derived from a carotene from diet was also added to the total. For cereals and millets, it is recommended to consume 50% as whole grains. For green leafy vegetables, GLVs, it is recommended to consume 150 grams of GLVs, especially drumstick leaves, amaranth and bitter leaves to meet the requirements of all the vitamins and minerals. So far we have discussed about the nutrient requirements during pregnancy. Let us now read in detail the effects of malnutrition on the health and nutritional status of the mother and the fetus/newborn. 13.5 Maternal nutrition and fetal outcome. Maternal malnutrition has deleterious effects on both the mother and the offspring. Inadequate energy intakes, iron deficiency and strenuous physical work all contribute to poor weight gain in the mother, increased morbidities, and in severe cases, resulting in increased maternal mortality. The effects of malnutrition in women including during pregnancy have been covered in the previous unit on women and nutrition. The focus in this section is on the fetal outcome in terms of birth weight. A large number of studies done especially in the developing countries have shown that maternal malnutrition seriously impairs fetal outcome. The birth weight and gestational duration are adversely affected while pregnancy complications such as stillbirth are increased in maternal malnutrition. Therefore, it is crucial to improve maternal nutrition status in order to improve the fetal outcome. In this section, the relationship between several parameters of maternal nutrition and fetal outcome are discussed, so that we have a good knowledge of the priority actions at the individual and at a public health level to improve the fetal outcomes. The World Health Organization, on the basis of worldwide data, has recommended that a full-term baby with birth weight less than 2.5 kilograms may be considered a low birth weight, LBW, infant carrying relatively higher risks of substandard growth and development and higher risk of perinatal and neonatal mortality. Low birth weight in full-term infants is chiefly attributable to poor maternal nutrition and health. The postnatal growth and development of the LBW infants is poorer than normal weight infants. More recently, the concern has been raised that the LBW infants may become more prone to chronic degenerative diseases later as adults. In the subsequent discussions, the effect of maternal anthropometric measurements on the fetal outcome shall be reviewed in detail. We shall begin with the weight of the mother prior to conception. 13.5.1 Pre-pregnancy weight and fetal outcome. Several studies from around the world from developing and developed countries have demonstrated an association between preconception body weight of the mother and LBW. The ICMR study in urban and rural India showed that preconception weight of less than 40 kilograms was a strong determinant of LBW. Another study conducted by the Nutrition Foundation of India, NFI, showed that body weight less than 45 kilograms was an influencing factor. The incidence of LBW in women with pre-pregnancy weight of 45 kilograms or more was 17% as against 30 to 33% in the poor communities in general. The ICMR study also demonstrated increased perinatal mortality of the infant if the mother's preconception weight was less than 40 kilograms. A favorable preconception weight in rural and urban Indian women would appear to be 45 kilograms or more within acceptable limits of body mass index, BMI. In any case, it should not be less than 40 kilograms, as this is associated with a high risk of delivering a LBW infant. Distressingly, according to data gathered by National Nutrition Monitoring Bureau, NNMB, 15 to 29% of adult women in different states have body weights less than 38 kilograms. This situation can only be remedied by addressing malnutrition in the girl child. Next, we will learn about the association of maternal height with the fetal growth. 13.5.2 Pre-pregnancy height and fetal outcome. Maternal height prior to conception, determined by heredity, socio-economic environment and maternal nutritional status, is a strong independent determinant of birth weight and mortality. The ICMR multicentric study in India found that incidence of LBW rose sharply when maternal height was less than 140 centimeters. Another study found a 2.5 times higher incidence of LBW in mothers with height less than 147 centimeters compared to mothers with height above 147 centimeters. Since the cutoff heights vary, it would seem again that preferably the pre-pregnancy height should be above 147 centimeters, but in any case less than 140 centimeters should be considered as high risk for LBW. Unlike weight, which can be increased at any time during the reproductive period, adult height once reached cannot be changed. The NNMB data from different states show that 12 to 25% of adult women have heights less than 145 centimeters. Therefore, all efforts must be done to prevent stunting in the girl child. This aspect will be discussed in further detail in Unit 14 on preschool children. Another important aspect which is gaining importance is the extent of adiposity or the optimal weight for a given height, i.e., the body mass index of the mother, and is being briefly discussed below. 13.5.3 Body mass index, BMI. Weight for height as a marker of nutritional status has the advantage that it is independent of other factors that affect fetal outcomes such as maternal age and parity. BMI is useful in predicting LBW or small or large for gestational babies. Refer to Table 13.5 to understand the relationship between increasing body mass index and reducing incidence of low birth weight babies. Table 13.5 Prediction of low birth weight on the basis of BMI. BMI less than 16 to 53%, 16 to 17 to 41%, 17 to 18.5 to 36%, 18.5 to 25 to 27%. 25 to 30 to 15%. Greater than 30 to 20%. It is well known now that the health status both before and after conception hold great significance for both the mother and the child. Remember, we read about maternal weight gain during pregnancy in the subsection 13.3.5. Let us now learn about weight gain during pregnancy and its impact on fetal outcome.
13th May 2004 Weight gain during pregnancy and fetal outcome. Weight gain and birth weight are indisputably related to each other. Several studies have shown a higher occurrence of LBW with inadequate maternal weight gain. It is suggested that a low weight gain after 20 weeks of gestation may result in preterm birth and low weight gain throughout pregnancy in LBW. A weight gain of 7 to 11 kg appear to be a measure of adequate fetal growth, although preferably it should be closer to 10 kg rather than 7 kg. Yet another significant factor is the food intake and dietary choices of the mother, which is being discussed next. 13th May 2005. Maternal dietary intake and fetal outcome. Among the various nutrients, energy intake appears to be the most crucial for developing countries. Studies from India have reported lower mean birth weight for lower income urban and rural mothers who had an energy intake of 1,200 to 1,600 kcal. Pre-pregnancy weight of 43 kg and a weight gain during pregnancy of only 5 to 6 kg. The mean birth weight of the infants was 2.7 kg. As against this, women from upper socioeconomic groups with energy intake of 2,000 to 2,500 kcal, pre-pregnancy weight of 45 to 55 kg, and a weight gain of 11 kg, had babies with a mean birth weight of 3.1 kg. It is not only the energy intake during pregnancy but chronic energy deficiency from early childhood that is a major factor in the low body weights of the lower income women. Therefore, body weight changes must occur much before pregnancy. Iron and folate are the other crucial nutrients that have an effect on birth weight. A recent review concluded that there was enough evidence to suggest that iron deficiency anemia resulted in higher occurrence of LBW through premature deliveries. Folate supplementation of pregnant women was shown to improve birth weights. Additionally, dietary folate deficiency is implicated in neural tube defect, as you may already be aware by now. Certain other factors which may influence the health status of the mother and/or the fetus are being elucidated next. 13th May 2006 Non-nutritional factors, antenatal care, age, heavy physical work and intrauterine infections. The incidence of LBW is lowest and mean birth weight is highest in the state of Kerala, which is attributed to better quality of healthcare and higher female literacy rate in Kerala. An ICMR study in 6 states of India has shown that average age of marriage in girls was 13.8 years and the age at consummation of marriage was 15.3 years. It should be noted that the age of 14 to 18 is a period of active growth, the period of adolescence. From the average weights and heights of Indian rural girls, it is seen that 68% of the girls will be at high risk of poor pregnancy outcome at the age of 14Y and the risk reduces to 24% at the age of 18 years. Thus, early age at marriage is another high risk factor for poor fetal outcome. Heavy physical labor even in advanced stages of pregnancy is another factor to contend with in the settings of developing countries like India. It is suggested that under warm environmental temperatures and in an upright posture, increased sympathetic activity could result in poor uteroplacental blood flow affecting the fetus adversely. The average gestational duration of full-term deliveries in poor communities in India is about a week shorter than in the well-off sections. This is attributed to the increased sympathetic via the heavy physical labor. Prenatal intrauterine infections could be another factor contributing to LBW. It has been reported that infants born in poor environmental backgrounds have increased IgM, immunoglobulin M, and antibody, which is a reflection of the high exposure to intrauterine infections. A WHO review has identified 43 factors that influenced birth weight and gestational duration. They are grouped into 7 categories for convenience. These include 1. Genetics and constitution, e.g., sex of the baby. 2. Demographic and psychosocial factors, e.g., age of the. 3. Obstetric factors, e.g., parity. 4. Nutritional factors. 5. Maternal morbidity during pregnancy. 6. Toxic exposures, e.g., cigarette smoking. 7. Antenatal care, number of visits and quality of care. The following are the salient modifiable factors which affect birth weight and gestation adversely: iron deficiency anemia, folic acid deficiency, inadequate pre-antenatal care. These are the factors that must be addressed as a top priority from public health point of view to improve fetal outcomes and reduce the high incidence of LBW in India. We will now learn about the significance and various aspects of nutritional care during, prenatal prior to, pregnancy. 13.6 Nutritional Assessment and Guidance in Prenatal Care. In the preceding sections, we have seen that there are unique physiologic changes in the pregnant woman's body, which has enhanced metabolic work that obviously accounts to the increased nutrient and energy needs. Thus, care during pregnancy is of special importance, and the first step required for this is a comprehensive nutritional assessment. As in case of any other person, this will provide the foundation for planning personalized nutritional care, education and guidance throughout pregnancy so that we can help ensure that both mother and baby are healthy. What should we focus on? Our focus should be strongly on the preventive aspects of nutrition, identify women at risk, recognize special needs for counseling, and plan an optimal follow-up nutrition care. Although nutritional needs are increased, there are individual differences and problems that may affect the nutritional status of the mother. The factors that may influence the mother's status include physiologic, psychological, situational, cultural, social, economic or personal. Among these, socioeconomically disadvantaged and adolescent mothers require more attention. When providing advice and counseling to the mother, it is important to remember that nutrition is essential to health in 2 ways, i.e., on a physiological level and on a personal level. We need to consider both of these in assessing the mother's needs and goals. Ideally, we should undertake preconception nutrition assessment and education, correct any deficits and promote a planned pregnancy. The care process, like any other, will consist of the parameters as mentioned in Table 13.6. Table 13.6 Essentials of a prenatal care process. Look at the screen. Having gone through the discussion above, the significance of adequate nutritional care must be clear to you. However, keeping in mind the high morbidity and mortality rate, it is essential to understand the common complications which may arise, especially among the disadvantaged sections of our society. Our next section will deal with some of these aspects. However, before we proceed, you need to attempt the following exercise, which will help you in getting a holistic view about the aspects discussed so far. 13.7 Common concerns during pregnancy. Many of the physiological changes that occur during pregnancy affect the digestive tract and may cause discomfort to the mother. Most of these problems are minor, but in some cases they may be more serious. Nausea, constipation, heartburn, pica, food cravings and aversions, as well as food sensitivities are common nutrition-related concerns. We may need to advise mothers about simple strategies to help avert them. In this section, however, we shall elaborate upon certain clinical conditions which may arise during pregnancy that may increase the risk for the development of complications during pregnancy, delivery and postpartum, and how to manage these. Let us begin with the study of these conditions. 13th July 2001 High-risk pregnancies. Until now we have considered the nutritional needs of pregnant women. In this subsection, we will consider specific conditions that contribute to high-risk pregnancies. Healthcare professionals favor health promotion with a preventive approach. Various factors have been identified which are associated with high risk. They are summarized in the table 13.7. Some of these, you will realize, cannot be changed as in case of personal characteristics, and some can be changed. Some are preventable and others can be controlled. Some problems are directly related to the pregnancy itself, such as anemia, hyperemesis gravidarum, extreme form of morning sickness, or pregnancy-induced hypertension. For some, the normal physiological stress imposes demands on a relatively poor maternal nutritional status or maternal reserves that are not sufficient to meet the new additional needs. Pre-existing diseases such as diabetes, chronic hypertension or phenylketonuria also pose risks. Hence, it is important to pay attention to such mothers. Adequate nutrition and consistent prenatal care can reduce the risk of premature delivery or low birth weight babies. High-risk pregnancies need special management, including intervention to correct malnutrition. This aspect is discussed next. Table 13.7 High-risk pregnancies, risk factors for poor pregnancy outcome and pregnancy-induced complications. Look at the screen. 13th July 2002 Management of high-risk pregnancies. Pregnancy-induced hypertension. Gestational diabetes. Although the risk factors are many, we will consider some selected factors, especially the nutrition-related ones. Let us have a look at these one by one. A. Anemia in pregnancy. Anemia is the most common complication and is often compounded by low socioeconomic status. However, it is seen frequently in upper-income women too in the absence of poverty. In majority of cases, the anemia is of nutritional origin, the main cause being dietary iron deficiency, which may date back to pre-pregnancy years. Acute blood loss caused by hemorrhage is a related cause. Folate deficiency, which is less common, results in megaloblastic anemia. Although it can exist singly, it usually occurs with iron deficiency. Anemia caused by other factors is less common. Iron deficiency anemia, microcytic hypochromic anemia, is widespread among adolescents and young women during their reproductive years. They become highly vulnerable when greater physiological demands are imposed by pregnancy. Since the iron cost of pregnancy as shown in table 13.7 is high, negative iron balance tends to occur. Iron deficiency anemia accounts for approximately 3/4 or more of the non-physiologic anemia in pregnancy. Physiologic anemia is a term used to indicate anemia due to hemodilution in normal pregnancy. Based on blood volume changes during pregnancy and the iron content of fetuses at different gestational ages, the iron requirements for pregnancy in an iron-replete non-anemic woman has been computed as shown in Table 13.8. Requirement. Table 13.8. Iron requirement for pregnancy. Look at the screen. The increase in iron requirements during the first trimester is minimal as menstruation losses are nil and transfer to the fetus has not begun, but the increase during the second and third trimester is quite large. The absorbable iron requirements are worked out to be 0.8 mg per day in the first trimester, which increases to 6.3 mg during the second and third trimesters. Assuming a 5 to 8% absorption of iron in Indian pregnant women, the dietary iron requirement in the first trimester is 10 to 16 mg per day that can be easily met through existing diets. However, in the second and third trimesters, the iron need simply cannot be met through the diet as it rises to a phenomenal 80 to 120 mg per day. If a woman begins her pregnancy with normal iron stores of 500 mg, then the amount to be provided will reduce to 30 to 40 mg per day. This is the basis on which pregnant women in developed countries are recommended supplemental iron of 30 mg per day. However, among the Indian pregnant women, stores of iron are likely to be negligent. Further, most women in India are already anemic even before the pregnancy commences. Computation of iron requirements for correction of anemia and pregnancy needs in Indian women have been worked out, and these estimates indicate that 60 to 100 mg elemental iron will be needed as supplements for pregnant women. On this basis, the Nutritional Anemia Control Program in India provides 100 mg elemental iron, 1 tablet daily for pregnant women in the second and third trimesters to be continued for 3 more months postpartum. The mother may not have adequate iron stores and dietary intakes may not fulfill the increased need for iron during the second half of pregnancy. Iron is required not only for hemoglobin synthesis but also to ensure adequate fetal stores that will last in the infant for the first 6 months of postnatal life. Up to 2 years of pregnancy, iron-rich diets are required to replace the iron lost during pregnancy and delivery. If there is a shorter interval between pregnancies, the drain on the mother's depleted iron reserves will be even greater. Hence, it is necessary to ensure adequate iron intake. In addition to dietary intake, an iron supplement is routinely prescribed. We will need to be alert that routine iron supplements may have unpleasant gastrointestinal side effects or imbalances with other trace elements of zinc. Also, excess iron intake may potentially mask inadequate pregnancy-induced hemodilution. While supplementation is needed, it is important to emphasize food sources of iron in the mother's daily diet. Pregnancy. The most common. Certain degenerative diseases may also arise during pregnancy. The most common ones being hypertension and gestational diabetes. These may regress after pregnancy or continue to progress throughout life. Let us now get to know about these conditions. B. Hypertensive disorders of pregnancy. Hypertension may have been existing before pregnancy. Alternatively, a mother may develop hypertension during pregnancy, a pregnancy-induced hypertension, PIH, which presents a serious complication. The cardinal symptoms are hypertension, proteinuria and edema, which usually occur after the 20th week of pregnancy. The onset of PIH may be signaled by unusual weight gain within a few days. Studies show that PIH incidence is higher in very young mothers, 20 years, or older mothers, 35 years, mothers who are underweight and whose nutritional status is poor, including deficits in energy, protein, vitamins and minerals, in those who have pre-existing vascular disease e.g. essential hypertension, type I diabetes mellitus or a familial predisposition. Several nutrients have been studied for their role in PIH. These include protein, sodium, calcium and zinc. Incidence of PIH is greater among underweight women who failed to gain weight normally during pregnancy. Research evidence therefore indicates that an optimal and regular pattern of weight gain is vital to support the pregnancy. Of course, prevention is best. However, if PIH develops, we need to advise the mother to have a well-balanced, nutritious diet with sufficient energy and protein. Sodium intake can be 2 to 3 g since dietary sodium intake should be moderate, but sodium restriction does not cure the syndrome. Maintenance of good nutritional status is important. Mothers should be aware and careful since severe PIH can cause convulsions and can prove to be life-threatening. Next, let us review pregnancy and diabetes mellitus. D. Pregnancy and diabetes mellitus. During pregnancy, a woman who has pre-existing chronic disease requires special care, especially in case of mothers suffering from diabetes. Diabetes developed during pregnancy is termed as gestational diabetes. Studies have clearly shown that patient education and intensive management for glycemic control can help the mother to have a healthy pregnancy, a healthy baby, and reduce the risk of complications. We need to emphasize to the mother that self-monitoring plays a very important role in maintaining a tight control on the blood glucose levels. For more details on control of diabetes, you may refer to Unit 12 in the Clinical and Therapeutic Nutrition course, MFN-005. Yet another important factor which poses increased risk during pregnancy and delivery is excess body weight, whether it is prior to or during pregnancy. Let us read about the consequences and management of overweight obesity with regards to pregnancy. E. Pregnancy and obesity. Obesity is associated with increased risk for gestational diabetes, hypertension, preeclampsia, perinatal mortality, and the need for induced labor or cesarean section. Lower weight gains are acceptable for overweight women because the fetus can receive a part of its energy requirements from the maternal stores. Studies have shown that obese mothers have the best pregnancy outcomes when they gain approximately 6 to 7 kg during pregnancy. The peoples. Each obese pregnant woman should receive individual assessment and be given nutrition counseling at the beginning and throughout the course of pregnancy. Weight management should be directed towards a slower rate of gain rather than weight loss at any time during gestation. Besides this, a carefully supervised exercise program should be recommended as adjuncts for cardiovascular fitness, maintaining a sense of well-being and normal blood sugar levels. Next, we shall read about adolescent pregnancy. F. Adolescent pregnancy. The pregnant adolescent is viewed as a high-risk patient, highly susceptible to suboptimal pregnancy outcome. Even when not pregnant, a teenage girl has difficulty meeting her nutrient needs. Nourishing a growing fetus adds to her burden. The competition between maternal and fetal needs places both mother and infant at a risk. The frequency of prenatal problems, e.g., toxemia, anemia, premature births, low birth weight, and increased maternal neonatal mortality is higher for adolescents than for adult women. Complications like iron deficiency anemia reflect poor diet and inadequate prenatal care. Prolonged labor reflects the mother's physical immaturity. Growth usually continues for 4 years post-menarche, although at a much slower rate than during prepuberty. Adolescent girls who become pregnant within 4 years of menarche at a low gynecologic age are generally considered biologically immature, and therefore, at a high risk. Thus, nutritional needs for an adolescent mother must be estimated, in addition to her needs for growth. The dietary intake must meet the requirements for pregnancy, as well as her individual needs at different stages of growth. Her nutritional requirements can be estimated by summing the RDI for the specific age and the additional recommendations. We do not have sufficient specific information on nutritional needs of pregnant adolescents. Energy expenditure of adolescent girls is variable, hence the best assurance of an adequate intake is satisfactory weight gain. This should be accomplished by individual counseling on the basis of estimates of body size, growth rate, and age and activity level. Special attention needs to be paid to the calcium and iron needs. Nutritional assessment should include pre-pregnancy weight, the gynecological age, the chronological age minus the age at menarche, and the dietary intake history and activity patterns. Attention should be given to the pre-pregnancy nutrient intakes and nutritional status, low intakes of nutrient-dense foods during pregnancy and restricted food intakes. Weight gain is another aspect deserving attention. Allowable or recommended weight gain could be higher than for adults. The weight gain required can be calculated by adding the following. Expected weight increase as a result of normal growth, non-pregnant, during the 9 months of pregnancy. The increase in weight may be much higher for a girl during the first year after menarche to almost 10 kilograms, 4 years after menarche. Increase is required to support pregnancy. If underweight, the increase that is needed to achieve average weight for height. In this unit, we reviewed in detail the physiological changes, nutrient requirements, and some of the common complications associated with pregnancy. In our next section, we shall study about the nutrition and health significance of lactation. 13.8 Lactation. Lactation is a physiologic process which has profound relevance for both the mother and the newborn. It is the period following pregnancy when the woman nourishes a fully developed and a rapidly growing baby with breast milk. A lactating woman secretes about 590 milliliters milk day in the first month, which increases to about 817 ml day by the 5th month. On an average, a well-nourished lactating woman secretes about 722 ml day. We need to understand the establishment and maintenance of lactation, if we want to help mothers with proper and effective lactation management and prevent lactation failure, especially in case of inexperienced mothers. During pregnancy, changes occur in the mother's breasts to prepare for milk production, and as you have seen, body fat are deposited to ensure that energy is available for lactation. The establishment and maintenance of lactation are determined by several factors, including the anatomical structure of the mammary gland and adequate development of the alveoli, ducts and nipples, initiation and maintenance of milk secretion, and the ejection of milk from the alveoli to the nipple. You may recall studying the anatomy of the mammary gland and the physiology of lactation in the Applied Physiology course, MFN-004, in Unit 12. We suggest you look up the unit once again now. This information will help you in grasping the concepts explained here better. The major physiological features of lactation are being discussed next. 13th August 2001 Physiology of lactation. Lactogenesis is the onset of copious milk secretion around parturition, triggered by a fall in plasma progesterone levels. Although some colostrum is secreted after delivery, 2 to 3 days, full lactation begins later. The first 2 to 3 days after delivery is a period of rapid lactation initiation, followed by the longer period of maintenance of lactation. This complex neuroendocrine process is facilitated by interplay of various hormones. Oxytocin and prolactin instigate the lactation process. Prolactin is responsible for milk production and oxytocin is involved in milk ejection from the breast. A cyclic process of secretory activity, Luminal distension and expulsion of milk into the duct system continues throughout lactation as directed by the suckling of the infant and the letdown reflex. Regular sucking stimulates the continuation of milk secretion. Milk removal from the breast is a product of coordinated interaction between suckling of the infant and letdown reflex of the mother, as depicted in the figure 13. 2. As the infant commences suckling, afferent impulses generated in the receptors in the areola travel to the brain where they stimulate the release of oxytocin from the posterior pituitary. Oxytocin travels through the bloodstream to the breast where it combines with specific receptors on the myoepithelial cells, stimulating them to contract and force milk from the alveoli into the mammary ducts and sinuses. Figure 13.2 Basic features of letdown reflex. Look at the screen. We all know that human milk contains several nutrients and that it is tailor-made to meet the requirements of the growing infant. The subsequent text will dwell upon the composition of milk with special reference to its influence on the health of the infant. 13th August 2002 Human Milk Composition and Infant Growth and Development. This subsection deals with composition of human milk, compares human milk with cow's milk and why human milk is preferred and recommended for infants. We will also examine the impact of mother's diet and nutritional status on the quantity, volume, and quality, composition, of human milk. Nature has designed milk to be species-specific. Thus, human milk is unique to the needs of the young Homo sapiens. The value of human milk for the health and growth of the baby is undisputed and rarely does breastfeeding need to be discouraged. The composition of the breast milk is described next. A. Composition of human milk. Research clearly shows that each type of mammalian milk is unique and consists of a highly complex mixture of organic and inorganic compounds. Human milk is a solution of proteins, sugar and inorganic compounds in which a variety of fatty acids are suspended. Its nutritional composition is presented in Table 13.9. Table 13.9 Nutrient composition of human milk. Nutrients and amount per 100 milliliters. Energy Cal 65. Protein G 1.1. Carbohydrates G 7.4. Fats G 3.4. Calcium Mg 28. Iron Mg nil. B-carotene Meg 13.7. Thiamine Mg 2. Riboflavin Mg 2. Niacin Mg nil. Vitamin C Mg 3. Milk composition varies between mothers, inter-individual variation, from one period of lactation to the next, intra-individual variation, and even within a single 24-hour period, diurnal variation, and the time during the feed, as well as the breast. The composition of milk is also related to the amount secreted, timing of withdrawal and individual variations, which includes maternal age, parity, health and socioeconomic status. Gestational age of the infant also affects, since milk from mothers of premature infants has higher concentrations of some nutrients as compared to milk from mothers of term infants. Similarly, diet and use of oral contraceptives may also influence composition. The concentrations of most nutrients fall between certain limits in the milk of healthy well-nourished mothers. The caloric value of human milk depends mainly on the fat content. Even after prolonged lactation for 2 years or more, the quality of milk produced by Indian and African women appears to be relatively well maintained, although the quantity may be small. Special characteristics of colostrum, beneficial to the infant, are summarized herein. Times volume of colostrum, 2 to 10 ml feeding day, related in part to the parity of the mother. Times typically yellow, due to a relatively high carotene content. Transparent, contains more protein, less sugar and much less fat. Lower in calories than mature milk, 58 versus 70 cal 100 ml. Times concentration of sodium, potassium, and chloride greater than in mature milk facilitates establishment of bifidobacteria in the gastrointestinal tract of newborn. Times facilitates passage of meconium in the newborn's intestines. Times abundant content of antibodies, passive immunity for infant. Colostrum changes to transitional milk between the 3rd and 6th day, at which time the protein content is still quite high. By the 10th day, major changes have been completed. By the end of the 1 month, the protein content reaches a consistent level. As the content of protein falls, the content of lactose and fat progressively rise, as lactation becomes more firmly established. The energy density of human milk depends on the relative proportions of protein, fat and the principal carbohydrate, lactose. Energy content is 5.65 kg of protein and amino acids, 9.25 kg of fat and 3.96 kg of lactose. Lactose content is 7 gdl and protein 0.9-1.0 gdl. Lactose contributes 40 to 45% of the calories and protein 5 to 6%. Fat concentration and energy density may not affect total energy intake of breastfeed infants, since those who nurse on demand apparently compensate for a lower milk energy density by consuming higher volume of milk. Triglycerides constitute 98% of milk lipid with wide diversity in the fatty acid composition. Medium-chain fatty acids are synthesized only in mammary alveolar cells, while both saturated and unsaturated acids, 16 C atoms, are derived either from diet or fat stores. Having studied the composition of breast milk, let us next get to know about the importance of human milk. B. Importance of human milk for infant growth and development. Let us now look at the value of human milk in promoting infant growth and development. Success of lactation must be judged ultimately by its adequacy for growth and health of the breastfed infant. Lactation performance can be evaluated from the weight gain of the infant in everyday life, although researchers have used a variety of methods. We have listed some characteristics that make breastfeeding beneficial to the infant. Mature milk contains about 1st March, the protein found in cow's milk. More than 25% of its nitrogen is non-protein nitrogen. The concentration of casein to whey protein is lower, 1.5 for breast milk and 0.2 for cow's milk. Thus human milk with its low casein content forms a flocculent suspension with a curd tension of 0. These curds are easily digested and hence better tolerated by the infant. Lactoferrin in human milk inhibits the growth of certain iron-dependent bacteria in the GI tract and therefore affords protection against gastrointestinal infections. Presence of phagocytes, lysozymes and lactoperoxidase afford immunity against harmful microorganisms such as S. aureus, Candida sp. Salmonella sp. Times. Point protection from respiratory tract allergy and eczema. Immunoglobulins provide passive immunity and protect against infection by retarding viral and bacterial invasion of the mucosa. Protective effects have been substantiated for necrotizing enterocolitis, acrodermatitis enteropathica, intractable diarrhea, pathogenic E. coli infection. Relatively low in amino acids that are detrimental at high levels. High in amino acids that infant cannot synthesize, e.g. cysteine and taurine. Lipids, Lower in formilking milk has a threefold higher fat content. Higher content of linoleic and oleic acid, cholesterol, the latter being needed for myelin synthesis. Contains lipase which helps in digestion of milk triglycerides and partly accounts for a greater ease in fat digestion of breastfeed infants. Higher levels of lactose and nitrogen containing oligosaccharides which have L-bifidus promoting activity. Minerals, as compared to cow's milk, 6 times more phosphorus, 4 times more calcium, lower renal solute load, better availability. Lower iron content but nearly 50% of iron in human milk is absorbed. Levels of water-soluble vitamins likely to reflect maternal dietary or supplementary intake. Several hormone-like substances and growth factors in human milk. The significance of human milk in maintaining the health of an infant was highlighted above. However, we all know that in countries like India, the prevalence of malnutrition is widespread and it can have serious consequences on the health of the mother and the quality of milk secreted. Read the subsequent text to learn more on this aspect. 13th August 2003 Malnutrition effects on milk and effects on mothers. Milk is the sole source of nourishment for many infants for up to 6 months or a year or even more. Therefore, the relationship between maternal nutritional status and lactation performance is important. Let us look into the effects of maternal undernutrition. Theoretically, we could expect both quantity and quality of milk to be affected. Volume, a large healthy baby who can vigorously suck will induce and obtain much more milk from its mother than a small, sickly or preterm infant. These differences in yield may not be indicative of a mother's capacity for lactation. However, studies on women from less developed countries including Ethiopia, Nigeria and on poor Indian women show that volume of milk produced is not adversely affected, since milk production is a function of infant demand. However, it is strongly affected by feeding other foods fluids. Energy, in case of chronic undernutrition, an association between postpartum weight loss and lower energy transfer may occur. In dietary supplementation trials, increasing maternal energy intake did not help much in increasing energy transfer except in women whose initial fat reserves were very low. In women with adequate fat reserves, apparently a gradual weight loss up to 0.5 kg week may not adversely affect lactation. Protein. Some studies show that the protein content of milk may be affected by chronic protein undernutrition. In some cases, the tyrosine content of milk was significantly lower. In Indian women, it was seen that the milk of malnourished mothers had more casein and less whey. By giving a high protein diet supplement, the whey-curd ratio could be increased. Fat content of milk appears to be subject to variability as compared to other constituents. The average fat content in milk from well-nourished mothers tends to be higher than milk from less well-nourished mothers. This may have implications for the caloric intake of the infant. Supplementing the mother with adequate intake of energy, protein and fat helped to increase the fat concentration in milk. Low levels of fat are apparently related to diet during lactation, inadequate energy intake in pregnancy and an inadequate amount of fat gain. The fatty acid composition of milk lipid is altered by the mother's diet, including the type and amount of dietary fat, total energy intake and carbohydrate intake. When lactating women were fed a diet rich in PUFA, their milk also had a higher PUFA content. Providing mothers with fish oil supplements increased the C-3 fatty acid in milk. When caloric intake is severely restricted, fatty acid composition resembles that of the depot fat. A substantial increase in the proportion of dietary glucose from carbohydrate results in an increase in the milk lauric and myristic acids. The proportion of medium-chain fatty acids was observed to be 30 to 45% on a low-fat diet. However, the total fat content was not significantly altered. What would be the effect on the micronutrient content of the milk? Let us read to find out. Minerals. There appears to be no relationship between dietary intake and concentrations in milk for copper, iron or zinc. Iron supplementation did not increase milk iron levels. In case of zinc, the milk concentrations may be influenced by maternal zinc intake within a physiologic range, and the effects of low maternal intakes are most apparent with prolonged nursing. Selenium content of human milk indicates that it is related to maternal selenium status. Vitamins. Although there are inter-individual variations in vitamin concentrations, diet and drug use by individual women influences vitamin composition in human milk. Vitamin D activity of human milk is influenced by maternal vitamin D intake, as well as maternal exposure to UV light. Concentration of vitamin A is strongly influenced by the mother's diet. Vitamin A content of breast milk has been found to be much lower in some developing countries than in Western countries. The levels of water-soluble vitamins are more likely to reflect maternal dietary or supplement intake than most other ingested compounds. In lactating women of low socioeconomic status, supplementation with folate, vitamin B12 and B increased the levels of each vitamin in milk. B in milk may be a sensitive indicator of maternal vitamin B status. There are reports of vitamin B2 deficiency in infants of vegan and malnourished mothers. So far, we have dealt with the various aspects of lactation and the importance of maternal nutrition for ensuring infant well-being. Let us now examine the impact of lactation from the mother's perspective. Effects on mother. Successful breastfeeding requires adequate nutrition and rest. For adequate lactation, substrates must be available in sufficient quantities from the mother's diet or body stores laid down during pregnancy. If these are insufficient, some degree of subsidy from maternal body tissue can be expected. As you well know, the simplest evidence of tissue depletion is weight loss. In a sense, pregnancy and lactation need to be considered as a continuum. Among well-nourished women, weight loss can occur after childbirth, although this depends on their caloric intake and their physical activity. In poorer communities, dietary intakes of breastfeeding mothers are not very different from non-lactating women. However, given the lower caloric intakes, weight loss during lactation may not always be as severe as might be theoretically expected. It is possible that changes in tissue composition may mask the changes in body weight. An increase in body water, concomitant with an increase in body fat, would result in great weight loss. However, the longer the duration of lactation, the greater would be the impact on the mother's nutritional status. Studies indicate that there are major physiological alterations in calcium and bone metabolism during lactation, independent of maternal calcium intake. Bone resorption and bone formations are high, particularly in the 3 to 6 months of lactation. Decreased urinary calcium excretion and increased absorption efficiency have been observed. We shall next discuss about the nutrient requirements of the mother during lactation, which are essential for maintaining her own health, as well as the normal composition of her milk. 13.9 Maternal nutrition during lactation. As we have already seen, the mother's nutrient intake must support breast milk production and can influence the nutrient composition of milk. In fact, you will find that the need for energy and many nutrients is even greater during lactation than during pregnancy. The maternal nutrient need is highlighted next. 13 September 2001 Nutrient requirements during lactation. Maternal nutrient requirements during the period of lactation include requirements for maintenance and activity and in addition, the amount of nutrients secreted in human milk. The latter would generally be determined from the yield and composition produced by healthy women with adequate lactation. Hence, you will realize that needs of women relate to the volume of milk produced. It is important to remember, however, that the requirement for a nutrient will be greater than the amount secreted in milk because the transfer of energy and nutrients from diet to milk is not 100% efficient. In practice, the mother subsidies lactation from the nutrient stores she has laid down during pregnancy and if not, by the loss of body tissues. Specific requirements. During lactation for many nutrients have not been extensively investigated. The LDs are generally based on allowances for the non-pregnant, non-lactating woman plus the amount secreted in the milk. You will need to remember that it is assumed that the mother is more than 18 years old, and she herself is no longer growing. Let us then get to know about the nutrient needs of a lactating mother. Energy and protein needs. Remember that during pregnancy, well-nourished women will have laid down approximately 2 to 4 kg of fat. This can be mobilized to supply a portion of the additional energy for lactation. It is estimated that this amount of storage fat will provide 200 to 300 kcal for a period of 3 months. However, this amount represents only a part of the energy cost of milk production. The volume of milk produced is assumed to be 722 ml based on ICMR 2020. With an average content of 82 kcal 100 ml, the daily output of energy would be 594 kcal. You must remember that the efficiency of milk production would be 80% or a maximum of 90%. Thus, an additional energy supply of approximately 600 kcal should be adequate to support lactation. The intakes recommended by the ICMR are shown in Table 13.10. Table 13.10, Recommended Dietary Intakes for the Lactating Women. Look at the screen. Note in Table 13.10, the RDAs for all major nutrients are given for the first 6 months of lactation, as well as the second 6 months of lactation, when the volume of milk produced has decreased. However, women who had a low pre-pregnancy weight gain, who have decreased weight for height and who breastfeed more than one infant, will more likely need additional kilocalories during lactation. FAO/WHO 2004 recommends that well-nourished women with adequate gestational weight gain should increase their food intake by 505 kcal for the first 6 months of lactation, while undernourished women and those with insufficient gestational weight gain should add to their personal energy demands 675 kcal during the first 6 months of lactation. Energy requirements for milk production in the second 6 months are dependent on rates of milk production, which are highly variable among women and populations. The additional protein intake suggested in Table 13.10 not only takes into account the additional protein needs but also the net protein utilization of Indian diets. The requirement of several micronutrients also increases and is summarized herewith. Micronutrient, vitamin and mineral deficiencies can have profound influence on the composition of milk. Calcium is a nutrient of special concern, since there are some reports in the literature that if the mother's diet is not adequate, it will be mobilized from her bones. This is especially of concern in case of prolonged lactation. Hence, the RDI for calcium is high for lactating mothers. The requirements for other nutrients are all increased, reflecting the need for milk production and the need to replenish maternal stores. Folate needs are increased above non-pregnant levels but are not as high as during pregnancy. Iron needs are not increased during lactation because little iron is lost in milk, and in most women, losses are decreased because menstruation is absent. However, if the mother's iron status is poor, supplements of 30 mg of elemental iron per day may be recommended for the first 2 to 3 months of lactation to replete iron stores. Besides these, water needs during lactation should be paid attention to. An increase in fluid intake does not increase milk volume, however, additional fluid is needed to maintain a normal maternal fluid balance. When fluid intake is low, the mother's urine will become more concentrated to conserve water for milk production. To avoid dehydration and ensure adequate milk production, fluid intake should be increased by about 1 per day. Now that we are aware of the nutrient needs, let us next study how to meet these needs of the lactating women. 13 September 2002 Dietary Management. Meeting the needs of lactation requires a varied nutrient-dense diet. Generally, a well-balanced diet will meet nutrient needs of the mother. Whenever feasible, food should be the source of nutrients and self-initiated vitamin and mineral supplements should be avoided. The dietary intake of caffeine, artificial sweeteners and alcohol must be totally avoided. This is because most chemicals ingested by the lactating mother cross into the milk. Therefore, the mother should seek the advice of her physician before taking any dietary supplement, any medication or drugs such as caffeine and alcohol, which also pass into the milk and consequently affects infant. Excess caffeine may make the infant irritable and wakeful, but the research indicates that moderate amounts of caffeine, 1 to 2 cups of coffee per day, will not harm or upset the infant. Large doses of coffee may interfere with availability of iron from milk. Ethanol appears in human milk in a similar concentration to the maternal blood, although acetaldehyde, which is the major toxic breakdown product of ethanol, does not appear in the milk. Alcohol may impair the milk ejection reflex, therefore, it is prudent to avoid alcohol intake when lactating. Further, infants metabolize alcohol inefficiently. Smoking also reduces milk volume. Infant exposure to passive smoke negates the protective effect of breastfeeding and offers against sudden infant death syndrome. Foods with a strong flavor may alter the flavor of milk. A few infants may be sensitive to particular foods, e.g., cow's milk protein. Hence, when the mother's diet includes such foods, the infants may experience discomfort. However, this may not happen to most of the infants. In general, the mother can eat whatever she likes. However, if she suspects that a particular food is causing the infant discomfort, she should consult the physician. If the food is eliminated for an extended time, appropriate foods should be substituted to ensure nutrient adequacy. Few other concerns linked with breastfeeding are highlighted next. 13 September 2003 Other concerns during breastfeeding. Let us look into some special concerns during breastfeeding that might be useful to you as a dietitian. Medical considerations. This is an area which needs consideration. If a mother has a communicable disease like tuberculosis or hepatitis that could threaten the infant's health, then the mother and baby have to be separated. The mother can express her milk several times a day and feed the infant. In case of a mother with HIV infections, though the virus can be transmitted to the baby through milk, breastfeeding the baby yet protects the infant. Women with chronic diseases such as type I diabetes continue to need careful monitoring and counseling to ensure successful lactation. They need to adjust their energy intakes and insulin doses to meet the heightened needs of lactation. Maintaining good glucose control helps to initiate lactation and support milk production. Many drugs are compatible with breastfeeding, but some medications are contraindicated either because they suppress lactation or can be secreted into breast milk and thus harm the infant. As a precaution, therefore, the mother should consult her physician before taking any drug. Weight loss. Some women may want to return quickly to their pre-pregnancy weight. It is important to remember that some women will lose more, whereas others may maintain or even gain weight. Moderate to severe caloric restriction and rapid weight loss is not recommended because it can decrease milk production. This is especially important in the early weeks of lactation before the process is firmly established. Therefore, a gradual rate of weight loss in the first 6 months and that exercise is the best way to reduce excess weight. However, intense exercise can raise the lactic acid concentration of breast milk, which influences the taste of milk. A study has shown that infants appear to prefer milk produced prior to exercise. Exercise. Among well-nourished mothers, those who exercised demonstrated a higher level of fitness, a lower percentage of body fat and higher level of energy expenditure as compared to sedentary women. There was no difference between the groups in plasma hormones or milk energy, lipid, protein or lactose content. Exercising women tended to have a higher milk volume. It has been recommended that energy intakes should not fall below 1,500 kcal/day at any time during lactation. The cost of providing adequate nutritional support to the mother depends mostly on what foods she can afford and selects. The cost of providing appropriate foods for the lactating mother is cheaper than feeding the infant with animal milk, if economical food choices are made. Human milk is a vital national resource, which could markedly improve the health and nutritional status of children. This section briefed upon the nutritional requirements of the mother during lactation and some general dietary and medical considerations to be borne in mind for maintaining a safe and healthy lactation. With this, we end our discussions on this topic and hope that the information given here would be of great help in managing diverse practical situations. 13.10 Summary. In this unit, we studied about the most crucial periods of a woman's life: pregnancy, a woman's life, pregnancy and lactation, especially from a nutritional point of view. We got to know that good nutritional care and a well-balanced diet can help to ensure that the mother herself and the infant will be healthy. Maternal nutrition has an impact on the health and nutritional status of the infant's growth and development. We learned about the role of various nutrients and the corresponding increase in their RDA in order to meet the increased needs. Generally, the requirements for energy and most of the nutrients are increased during pregnancy and lactation, especially for adolescents and women with multiple pregnancies. Adequate monitoring and care has a crucial role in ensuring satisfactory health of the mother. Dietary restriction for weight loss is contraindicated, especially during pregnancy, if the mother is obese. In our next section on lactation, we got to know the role of adequate nutrition during lactation. We also discussed about the composition of human milk and potential benefits of breastfeeding. Finally, we learned about the different disease conditions and their effect on the process of breastfeeding. Thank you. Subscribe to our channel for more updates, and we will see you with the next chapter.